Okay, so forget everything you think you know from TV dramas. Real-life resuscitation? It's so rarely about just pushing on a chest. We're going to go way beyond the basics to decode the incredible, high-stakes puzzle of cardiac arrest. We're going to find out how the real experts read the clues to save a life when the standard playbook just isn't working.
And this, right here, this is the whole game changer. The latest guidelines are making it crystal clear. That old one-size-fits-all approach, it's over. We are now in an era of precision resuscitation, where the goal isn't just to blindly follow an algorithm, but to become a detective and figure out why the heart actually stopped in the first place.
So here's our roadmap for today. First, we'll look at why standard CPR, as important as it is, sometimes just isn't enough. Then we're going to learn to decode the heart's secret language, the ECG. After that, we'll dive into some real-world case files, looking at everything from chemical imbalances and poisons to straight-up mechanical failures. And finally, we'll pull all those pieces together to really get inside the expert resuscitator's mindset.
You know, it used to be that resuscitation was all about being a really skilled technician. You just had to know the steps and execute them perfectly. But today, the game has completely changed. It's now about being an expert diagnostician, someone who is actively hunting for the root cause of the arrest in real time. It's way less about a flowchart and so much more about solving a mystery.
This slide just nails the difference, doesn't it? You have these two mindsets, the standard algorithm. Push hard, push fast. That's the foundation. It's absolutely vital, you can't skip it. But it's not the whole story. The expert sees the exact same situation, but they're asking totally different questions. They aren't just running a code, they are solving this incredibly complex puzzle, interpreting all these subtle signals to find and, hopefully, reverse the underlying problem.
So, how in the world do they solve that puzzle? Well, they use a mental checklist, and it's often called the H's and T's. You can think of it as a cheat sheet for the most common but hidden causes of arrest. And these are the special cases where standard CPR will fail every single time, unless you can identify and fix that very specific issue, like a toxin or a major metabolic problem.
And to find those clues, the expert's #1 tool, by far, is the ECG. But they see it in a way that most people don't. To them, it's not just some squiggly line on a screen. No, it's a direct window into the cellular health of the heart, and it's speaking the language of its most fundamental electrical machinery.
So here's the really cool part you have to understand. Every single little bump and wave you see on that ECG is created by these tiny charged particles, we call them ions, moving in and out of the heart cells. And the two most important players in this whole dance are sodium, which is what kicks off the heartbeat, and potassium, which is what resets it for the next beat.
Okay, so here's where we connect the dots, from a problem at the microscopic level to a huge clue on the screen. If something, let's say a drug overdose, blocks those sodium channels, the electrical signal just can't travel as fast. So what does that look like on the ECG? It looks like a wide, stretched-out QRS complex. An expert sees that, and their mind immediately thinks, we've got a sodium channel problem.
Now, let's flip to the other side of the coin. What if the potassium channels are disrupted? Let's say by dangerously high potassium levels in the blood. Well, the heart really struggles to reset itself. And this creates a very, very specific signature on the ECG. A tall, pointy, almost tented-looking T wave. It's another critical piece of that puzzle. All right, enough theory. Let's put this into practice with our very first case file, hyperkalemia. That's just the fancy term for dangerously high potassium. And trust me, this is one of the most common reversible causes of cardiac arrest, especially for patients who have kidney failure.
Hyperkalemia is famously known as the great imitator, and for good reason. It is a master of disguise. It can look like almost any heart rhythm problem you can imagine, which is exactly why being able to read those specific ECG clues we just talked about is so critical to unmasking the true culprit.
An expert can literally watch the story of a dying heart unfold right there on the monitor. As the potassium levels climb, first you see those peaked T waves we mentioned. Then, the P waves start to flatten out and disappear. Next, the QRS complex gets wider and wider. And finally, the whole thing just merges into this smooth, undulating sine wave, which is basically the heart's last cry for help before it stops completely. Now, the treatment for this is just incredibly clever. You don't just give the standard arrest drugs. The first, most critical thing you do is give calcium. Now, calcium doesn't actually lower the potassium, but it acts like a shield, stabilizing the heart muscle in less than 3 minutes. So while the calcium is protecting the heart, you give insulin, which acts like a key to unlock the body's cells and shift all that dangerous potassium out of the blood and back where it belongs. Okay, so we've gone from a chemical imbalance inside the body, now let's turn to a poison from the outside. A toxicological arrest is really unique because you often have a perfectly healthy heart that's just been temporarily stunned. If you can find the right antidote, you can bring it right back.
Hey, remember those slow sodium channels? Well, certain drugs, like some old-school antidepressants or even cocaine, cause that exact same problem. The expert fingerprint on the ECG is that wide QRS complex we saw before, plus a very specific clue, a tall, positive wave in a particular view of the heart called AVR, which is almost always negative. When you see that commentation, it absolutely screams poison.
Now, for a totally different kind of poisoning, like from a beta blocker overdose, one of the most powerful treatments we have is something called high-dose insulin therapy. And when we say high dose, we really mean it. The starting bolus dose is an incredible 1 unit per kilogram of body weight.
And just to put that number into perspective for you, that is 10 times a typical dose you would give a patient with diabetes. We're talking about a mega dose of insulin, not to control sugar, but to act as a kind of super fuel for the starving heart muscle. It's a really extreme, but often life-saving intervention.
And this next one, this is one of the most fascinating concepts in all of toxicology. For certain poisons that are fat-soluble, like local anesthetics that accidentally get into the bloodstream, you can actually give an infusion of a fat emulsion. The theory is that this creates a lipid sink in the blood, literally pulling the poison molecules out of the heart tissue like a magnet. How cool is that?
So the big takeaway here is that for so many poisons, there's a specific key. For those sodium channel blockers, the key is sodium bicarbonate. For beta blockers, it's that high-dose insulin. For local anesthetics, it's the lipid emulsion. The expert knows exactly which key fits which lock.
Okay, we talked about these really complex chemical problems, but sometimes the heart stops for a much simpler reason. It's a purely physical, mechanical failure. It's a plumbing problem. The electricity might be working just fine, but the pump itself is broken.
This right here is the classic resuscitation mystery. You look up at the monitor and you see what looks like a perfectly healthy electrical rhythm, but when you check the patient, there is absolutely no pulse. So what on earth could possibly be going on here?
Well, one of the main culprits is something called cardiac tamponade. This is when fluid, and it's usually blood, fills up the sac around the heart and literally crushes it, so it can't fill or pump. And there is a very specific ECG clue an expert looks for, called electrical alternance. As the heart is swinging back and forth in that fluid-filled sac, the QRS complexes alternate in height. Big one, small one, big one, small one. It is a dead giveaway.
So how does all of this come together in the heat of the moment? I mean, we've looked at all these different cases, but the real skill is being able to synthesize all these clues in the middle of a chaotic emergency. It's about building a coherent mental model and doing it fast. This is the expert's workflow in action. It's this rapid, systematic process. First, they analyze the QRS. Is it wide? Maybe suggesting a toxin or a potassium issue? Or is it narrow, pointing more toward a plumbing problem? Next, they're analyzing the other intervals, looking for more subtle clues. Then, and this is crucial, they consider the context. Is this a patient with kidney failure? Is this a known overdose? A trauma victim? By matching that electrical pattern to the clinical context, the expert can move beyond the standard algorithm and deploy a very specific life-saving intervention. So, as we get better and better at decoding these signals, the real question is, how will this precision approach change the future of saving lives?